Brian Lehrer on WNYC. In 2019, Donald Trump, during his first term, stood before Congress and made this pledge.
My budget will ask Democrats and Republicans to make the needed commitment to eliminate the HIV epidemic in the United States within 10 years. We have made incredible strides, incredible.
A pledge to end the HIV epidemic by 2030. Well, here we are 7 years later, and it looks like the Trump administration has done something very different. Since returning to the White House, Trump has cut HIV prevention grants, shut down advisory committees working on policy initiatives, and allowed World AIDS Day, December 1st every year, to pass without a word from the White House. That's all been widely reported. Now comes another blow. This one's related to a new federal rule on its way in about Medicaid. The rule requires certain Medicaid recipients to work, volunteer, or attend school for at least 80 hours a month or lose their coverage. That would start January 1st next year. It includes a, quote, medically frail exemption, but advocates say that that exemption is written so narrowly it could leave many thousands of people with HIV in a vulnerable position. In New York State, nearly half of all people living with HIV, which is an estimated 55,000 or so people, depend on Medicaid for their health care. Nationwide, Medicaid covers 40% of people with HIV at any given time. In addition to covering treatment and keeping people with HIV alive, Medicaid also funds things intended to prevent transmission. So we'll talk now about what these imminent Medicaid work requirements might mean for the New Yorkers and others who rely on Medicaid for HIV care. Our guest is Ginny Shubert, co-founder and senior advisor of Housing Works. As many of you know, one of New York's leading organizations serving people living with HIV and AIDS. Ginny, thanks for coming on for this. Welcome back to WNYC.
Thank you for having me.
And listeners, are you a New Yorker living with HIV or AIDS or who depends on Medicaid or both, or do you work in HIV care or services? You're invited. What does Medicaid mean for your care or your community, and what are you most worried about with these new work requirements? Your calls can be about the work requirements, whether or not they pertain to HIV with you, so we can open it up that broadly. But 212-433-WNYC, 433-9692, call or text. Ginny, remind our listeners about the people Housing Works serves. Who are we actually talking about when we talk about New Yorkers on HIV with Medicaid?
Well, most people think of Housing Works as our thrift shops, but actually the thrift shops are just the way that we fund our life-saving services and advocacy. So we operate 6 community health centers in underserved New York communities where we provide primary care, substance use treatment, mental health care for over 10,000 New Yorkers a year. Among the people that we serve, about 16% are uninsured and 66% rely on Medicaid. 82% of our patients rely on some form of public health coverage that's likely to be cut by H.R. 1. So the people that we serve and have since the beginning are those that are most marginalized in the community, people living with HIV, but also with experiences of homelessness. About 41% of our patients are homeless at any one time. People who have had experiences of incarceration, mental health issues, substance use disorder.
People in New York City may have seen public service announcements that say the words undetectable equals untransmittable. Undetectable equals untransmittable. That means that someone on effective treatment, even if they're HIV positive, cannot pass the virus on. What does Medicaid have to do with transmission, and what do you anticipate happens to that public health equation if people lose coverage?
Well, H.R. 1 work requirements and let's just say this is the first time in the history of the program that work requirements have been imposed, is harmful enough, and the Congressional Budget Office predicts it'll toss at least 6 million people nationwide off of coverage. But the new interim final rule that was published last week undermines a protection that Congress put into the law to prevent interruptions of coverage for people who are medically frail and require ongoing continuous medical care to manage their condition, like people with HIV, people with cancer, and other serious and complex medical conditions. Now, this is going to accelerate the harmful effect. What the interim final rule does is impose a new requirement that is not in the law, that not only does a person have to have one of these conditions, be medically frail, but they have to prove that their medical frailty prevents them from substantially complying or substantially impairs their ability to comply with the work requirements. Now, that's going to toss a lot more people with complex medical conditions off care. And for people with HIV, this is particularly dangerous because, as you point out, if you are retained on antiretroviral therapy, your virus is suppressed to a very low level, which means that you maintain optimal health and you literally cannot pass the virus on to others. If that treatment is interrupted, then your viral load resurges, your health declines, you progress to AIDS, and you also can now transmit the virus to others. And that is not only an attack on individual health, that's an attack on our public health.
Here, I guess, is what some of the pushback might be on your objection to this rule. And again, we're talking about a newly released federal rule about Medicaid work requirements that flow from the so-called One Big Beautiful Bill Act from last year that imposes Medicaid work requirements conceptually starting January 1st of next year. So now specific rules are coming out about that, and this one requires many Medicaid recipients to work, volunteer, or attend school for at least 80 hours a month or lose their coverage starting next January 1st. That has pretty broad public support in national polls, that if somebody is able-bodied and they're getting assistance from the government for something like their health insurance, then they should be expected to work or volunteer or at least be attending school, to be preparing to work. And especially, they would say, with this medically frail exemption to that, and what you were describing about these people taking the preventive treatments that leave them, in many cases, pretty healthy, in addition to incapable of transmitting the virus. Why isn't that a fair social contract?
Well, I have to say, first of all, that nationally and in New York, about 63% of people on Medicaid do work. But often they have to rely on Medicaid to keep them healthy enough to work. And if that coverage is interrupted because they can't navigate the bureaucratic process, or they can't pull together not only evidence of their complex and serious medical condition, but also their inability to comply with the requirements, then they will lose that coverage. So it's not that people are not working. We're talking about a group of people that make $22,000 or less a year, and many of them rely on Medicaid for their health coverage.
But you just said about two-thirds of them, 63%, are working. I guess who's at issue here is that other 37%, some of whom are going to be medically frail or have other reasons for exemptions that will exist under the law. But then what's the issue with requiring the rest of them to work if they're getting the benefit?
The issue is not whether they're working, it's whether they can meet the bureaucratic requirements to demonstrate that work. For example, a person with HIV or cancer has a health emergency or loses a job, and for a short period of time, they're unable to meet the 80-hour a month requirement. There is, I have to say, this has been tried. It was tried in 5 states that got federal approval to impose work requirements, and it failed miserably. There's no evidence base for this. In the states where it was tried, it was most often stopped by the courts because what it did was just cause a massive loss of coverage. It did not increase employment or community engagement because there's nothing here to help people find work or to ensure that they have opportunities. All that happens is they lose their Medicaid if they can't navigate the bureaucratic
Right.
process.
It does say, though, that they could also be doing volunteer work, which is also available to people.
That's true, but they also have to demonstrate that every 6 months they meet the 80-hour requirement. It's
Here's
an
a
onerous
text.
burden.
Here's a text from a listener who says, texting from Brooklyn, I've been living with HIV since 2018. I'm an artist and work freelance. I don't always have 80 hours a month of work. I currently take Biktarvy, which is $7,000 per bottle, $7,000 for a 1-month supply without insurance. Without Medicaid, I'm toast. So that's probably pretty representative of the people you're concerned about here, right?
Exactly, and the people that Congress was concerned about who are likely to experience severe adverse consequences if their care is interrupted, whether it's HIV or cancer or another complex and serious medical condition. For HIV, it's a lifelong, serious and complex medical condition that requires continuous access to health care and medications. And if that's interrupted, the consequences are very severe for the individual and for all of us, our public health system.
You're with Housing Works, which is an HIV-related organization. Listener writes, what is the outlook for HOPWA grants, that's housing for people with AIDS, from HUD? Are those being targeted or cut?
Well, President Trump would have zeroed out HOPWA in his FY27 skinny budget. Right now, in the House subcommittee that approves appropriations or handles appropriations for HOPWA and Health and Human Services, their proposal would make a $1 billion cut to HIV services, which would be devastating, not just for people with HIV, but for the whole infrastructure that serves people with HIV. If someone loses their Medicaid coverage, there's the Ryan White program, which has been level funded since 2014, and something called the AIDS Drug Assistance Program that can cover medications. But those programs are already wildly overstretched. They've been flat funded forever. And Congress, at least this Appropriations Subcommittee, would make dramatic cuts to those programs. So I agree with the caller that people will be placed in a dire situation. And in the demonstrations that I mentioned, one of the effects was that people with chronic conditions were more likely to lose their coverage, and as a result, they either went into medical debt or they delayed medical care or taking medications.
A little while longer with Ginny Shubert, co-founder and senior advisor of Housing Works, the HIV, people with HIV related organization, as we talk about a new federal rule that's supposed to take effect in January of next year, recently announced, so people are starting to have to get ready for it, that unless you have a medically frail exemption, you're going to have an 80-hour-a-week work requirement to keep your Medicaid benefits. That's, of course, for people making little enough money as it is to be on Medicaid, and we're inviting your stories that are relevant or questions for Ginny Shubert, 212-433-WNYC, 433-9692. Call or text. I see that Arkansas tried Medicaid work requirements at this level back in 2018. What happened there, and are there lessons for New York from that example?
Well, a court finally stopped that demonstration because, as I pointed out, all it did was result in severe coverage loss with no increase in work or community engagement. So it was so harmful that it was stopped. And it failed at what is the ostensible reason for the work requirements, which is to get people more engaged. And in large part because there was nothing to help people get work or attain self-sufficiency. They just lost their Medicaid. And in most cases, it was because they either didn't understand the new requirements or they were unable to navigate the complex system to ensure the continuation of their Medicaid. Many of the people that we work with, especially people experiencing homelessness, don't have a regular address. Their phones are stolen. It's very hard for people, marginalized people in our community, to stay on top. They don't have a computer or access to a computer to stay on top of these kind of requirements. So, I think, look, this substantially impairs ability to comply language came at the last minute. CMS had been working with states for most of the year to prepare them because it's a very fast-track change. And it had never been mentioned until the final rule. In fact, Nebraska implemented early in May, and this was not part of the implementation, which they worked out with CMS. So what happened? I have to point out that these work requirements were included to fund tax cuts, and the substantial savings that are predicted from imposing the work requirements can only be achieved if you save money by knocking people off their coverage who actually need the coverage and use it to manage difficult medical conditions. So kicking a bunch of healthy people who don't really need or use their Medicaid coverage is not going to achieve the savings they need to fund these tax cuts.
Here are some very specific questions coming in about the requirements from a couple listeners. One just says, how will it work for self-employed people to prove that they are working? Another one says, can Ginny Shubert speak to this hypothetical? John lost his job and was out of work in April and May. In June, he worked 80 hours in a new job. In July, he applies for Medicaid, but his state uses a 3-month look-back period to verify compliance. John would not qualify for Medicaid as he was out of work in 2 of the past 3 months. So take that multi-step hypothetical first. Is that a scenario, hypothetical, the listener writes, that you're familiar with?
Yes, that's a scenario that is very likely, especially with someone with whose employment is precarious, or who has a medical condition that changes over time. So there may be times when they can work and times when they cannot work. Now, fortunately, New York State, at least so far, have been allowed to have a 1-month look-back period. But again, what if that person was able to work in the first 2 months, but they couldn't work in the 3rd month? Even with a 1-month look-back period, they would be ineligible.
And to the other question, how will it work for self-employed people to prove that they are working?
That would be difficult. And eligibility specialists will have to figure out how to prove that employment. The states are working hard to implement this program. The H.R. 1, the bill, requires them to the extent possible to use electronic records and not have to contact the recipient to establish compliance. In the case of medical frailty, most states have been preparing to look at medical diagnoses and be able to determine who's medically frail and therefore exempt. Now that's thrown out the window because each person will also need some kind of evaluation of their ability to comply with the requirements, which is substantially impairs the ability to comply. Is not defined in the reg. It's very vague. It's not something most medical providers are competent to do. And it's going to be very difficult for states because they face severe penalties if CMS determines that they're not complying with the regs as they have stated them. So states are going to have to be very careful and will probably be overcautious in certifying something like self-employment.
By the way, a listener says that I made a mistake a minute ago in one of my references to the work requirement, and instead of saying 80 hours a month, which we've been saying, that I said 80 hours a week one of those times. So if I slipped up and did that, to be clear, nobody's requiring anybody to work 80 hours a week to stay on their Medicaid, but 80 hours
only the eligibility specialists who will be having to handle it.
Which I think leads us to Kevin in Inwood's call about how this went in Georgia. Kevin, you're on WNYC. Hello.
Hi. Yes. And just to be clear, I'm really grateful that you're talking about this topic. I moved to New York and right after 9/11. I have narcolepsy, which is a chronic condition and never goes away. And I had freelanced, and I've relied on Medicaid between jobs, that provide health insurance, even while I was freelancing. And these requirements, if you don't have the health insurance, even when you're looking for a job and you lose essential medicine, you don't have the energy to look for work. So it is a self-defeating program. And in addition to that, so I've become very passionate about this topic, and I've learned about the fact that, as your guest said, work requirements, the whole argument is that the government will save money by pushing people off the program. But when Georgia instituted work requirements in an offshoot of Medicaid, so it's a slightly different program, they spent $25 million in admin costs compared to just $7 million spent covering people's health care. So that's over 3 times as much money spent scrutinizing people's deservingness for the program as was spent actually providing health care, which is what Medicaid was supposed to be for.
Kevin, thank you for that. And I don't know if that stat is true. I don't know if you're familiar with that. But yeah, it's certainly going to cost them something more to be doing the new scrutiny of all these Medicaid recipients, and whether that's going to cost them more than the actual benefits that the government will be saving on the people they cut off.
The caller
I don't know,
is correct.
but it's an interesting question. You're familiar with the Georgia case?
Yes, the caller is correct. That was ended because the administrative costs swamped the savings.
So, as we run out of time, where does all this, as well as the Trump administration's withdrawal from HIV prevention and care in other ways, leave the goal of ending the HIV epidemic in the United States by 2030? People who have been with us since the beginning of the segment heard the Trump clip we played from his first term, where he declared a goal of wiping out HIV in this country by 2030.
I think it puts it out of reach. And let me focus on New York. In New York in 2015, we adopted a plan to end our epidemic because we have the science to do it. Antiretroviral therapy taken as treatment or prevention can stop new infections and maintain health for people with HIV. Even without a cure, we can stop it. We've made huge progress in New York. We've reduced new infections about 36% over the last decade, whereas in the country as a whole, there's been no decline. Right now, 91% of diagnosed people with HIV are in care, and of them, 89% are virally suppressed. That's huge. That's a huge accomplishment. This threat to Medicaid coverage for half of the people with HIV in New York will undermine what we're doing in New York State to end our epidemic. It will undermine public health in New York State, as inevitably the HIV epidemic will resurge. And it undermines our safety net health system, because when people go to a community health center or a hospital without Medicaid coverage, that provider receives no compensation. So it's going to cost jobs. It's going to erode our healthcare system. It's going to erode our HIV response overall. It's going to be quite devastating, and people will die.
That answer suggests one follow-up that I have to get in before we go. This is a federal rule. You were just describing the progress that New York has made compared with other states. What's the Hochul administration doing? Is there any pushback or workaround at the state level if this federal rule goes into effect as scheduled on next New Year's Day?
The state health department has been working hard to prepare with the guidance that CMS gave up until this rule to be able to identify people electronically who are medically frail and protect them from treatment interruption. That's now undermined by this new interim rule, if it stands. I think it might be challenged in litigation, but that takes time. Overall, though, since you invited the question, it's a bit disappointing in this year's budget. The state made no additional investments in our ending the epidemic effort to compensate for any of the lack of support that we're getting at the federal level.
Ginny Shubert, co-founder and senior advisor of Housing Works. Thanks for some time today. Thank you very much for talking this through with us.
Thank you for addressing this issue. I think a lot of people think AIDS is over. It's not over. We have the science to end it, but we just don't have the will.